with Francesca, and we look forward to sharing our first set of results with all of you this afternoon. Brendan.
And Abdullah, did you?
Yeah. I'm just Abdullah. I'm a staffer here at the People, Place, and Health Collective, and I assist with some of the dissemination side of things.
Fantastic. Thank you, Abdullah. And Brandon, just to the next slide. Just to give folks a quick overview of the agenda today, we have welcomed you and introduced the research team. Dr. Marshall and Dr. Bodwin will give an overview of this study procedure and the outcomes for about 20 minutes, and then we'll finish with a Q&A session at the end. So feel free to drop questions in the chat that we can come back to later. You can send them directly to myself or Abdullah, or open in the chat, and we'll call on you if you like in the Q&A session. So I'll just hand over to Dr. Bodwin to get us introduced to the Navigator trial.
Thank you so much, Brendan, and welcome again, everybody. I'd first just like to take a moment to acknowledge first the study sponsor, Arnold Ventures. We really did this study at the outset in partnership with Arnold Ventures, and they made this possible, but not without great partnership in both within the hospital system, Rhode Island Hospital and the Miriam Hospital, the recruitment sites for this study, but also our many state partners, including the Anchor Recovery Community Center, and also our state agencies, the Department of Behavioral Healthcare, Developmental Disabilities, and Hospitals, and along with the Rhode Island Department of Health. And so this really was a cross-institution collaborative study that was possible. And many thanks to our study participants and also research staff, some of whom are present on this call today, who helped get this study done and made this findings possible. Next slide, please. So we're going to start with just a brief overview of why we did this, rationale for the study, background, the overview of the study design, and I'm going to turn it over to Brandon to walk us through some preliminary results. So first, why the emergency department? There is a lot in the literature about using the emergency department as a teachable moment and focusing interventions for substance use in the ED. We in particular think that this is an opportune time to perform public health interventions, particularly for addiction and opioid use disorders. We know that patients with opioid use disorders are more likely to visit the ED than the general population, and that this is a place where we can potentially intervene and set people on a different pathway to recovery. Some preliminary work has demonstrated the effectiveness of ED-based behavioral interventions, including peer-led interventions for addiction treatment. And this is an environment where we already do other harm reduction services such as naloxone. So we felt that this was a good place to further investigate which interventions work, specifically focusing on behavioral interventions. Next slide. And then this gets to the second piece. Why did we look at a peer-led intervention? Rhode Island was one of the first in the country to examine an ED-based peer-led intervention delivered by peer recovery support specialists. And so we had access to some infrastructure that made this study really feasible. And there were very few studies that in a rigorous way, meaning a randomized controlled trial, evaluated the effectiveness of peer recovery support services. And we knew that the program in Rhode Island was starting to be replicated elsewhere, but without a significant amount of evidence behind it. And not just the peer-led intervention, but doing ED-based behavioral interventions at all. So it was a really opportune timing to examine this question further. Next slide. So ultimately, the question that we were attempting to address was, what is the effectiveness of a peer-led versus a standard intervention? And in this case, standard intervention delivered by a licensed clinical social worker, delivered in the emergency department for people at high risk of an opioid overdose.
Oh, that's a stain. Should I try to get it out?
I think some people are unmuted, so if you could just mute your mics until the Q&A session, that would be great. This is an overview of study recruitment. We think it's important to understand how we identified potential study participants. So our research staff diligently screened a consecutive sample of patients presenting to the emergency department using the electronic health record. So they looked at everybody coming into the emergency department, almost 24 hours a day, 7 days a week throughout the study period. We did have some pauses for the study in the early days of the pandemic, but most of the time we had 24/7 coverage for study recruitment. Those that were identified as potentially eligible were approached in person and screened for further eligibility. And then those that were eligible were invited to participate and underwent informed consent. Individuals were then randomized to either receive an intervention, a behavioral intervention from a peer recovery support specialist or a licensed clinical social worker. And I'll talk a little bit more about what that entailed shortly. And then all participants completed baseline assessments while they were in the emergency department. So this was about 45 minutes of surveys, some that happened before the intervention, and then some about attitudes toward treatment and willingness to access treatment. Those type of assessments happened after the intervention. But our key study outcomes were obtained from objective databases. So we thought that for this study, we knew that retention was going to be potentially an issue with this study population. And so we obtained our outcomes objectively from administrative data sources, the prescription drug monitoring program, and data from BHDDH who had treatment from licensed treatment facilities in Rhode Island. Next slide, please. Study participants were recruited from 2 emergency departments in Rhode Island Hospital and the Miriam Hospital. There are 9 emergency departments in Rhode Island, and these 2 together are close to, I think, about 40% of all of the emergency department visits in the state. And Rhode Island Hospital is a tertiary level 1 trauma center, and Miriam is a community affiliate, but is an academic affiliate, and they're both located in Providence, so in a more urban environment. Next slide, please. Eligible patients were adults. They did have to speak English, and this was mainly because our interventionists were not bilingual or multilingual, and so they had to be able to speak English in order to consent and participate. Participants had to endorse receiving most of their healthcare in Rhode Island, since we were linking to Rhode Island administrative data, that we wanted to make sure that people could be observed in those data sets. We did exclude patients that were pregnant or in police custody or incarcerated. And people had to be in the emergency department for one of 3 reasons. And this is key. They had to be in the emergency department because they had just experienced an opioid overdose, and that's why they were there. They had to be in treatment related to an opioid use disorder and presenting to the emergency department. This should actually say that they should be in the emergency department with a sequelae of an opioid use disorder, meaning an abscess related to injection drug use or endocarditis or opioid withdrawal. And then the last eligibility criteria was having had a recent opioid overdose. Next slide, please. The 2 arms of the intervention were delivered by different types of interventionists. One, the licensed clinical social workers. Without getting into full details, kind of the overarching commonalities between these 2 is that they did draw on similar intervention techniques such as motivational interviewing, assessing social supports, readiness for change, readiness for treatment. However, a key distinction is that social workers rely on clinical experience and social work theory and practice, whereas the peer recovery support specialists rely on lived experience. Our peer recovery support specialists that were interventionists in this trial were themselves in recovery for at least 2 years and had undergone a 45-hour training program with additional supervised work experience. In addition, the peer arm of the study, there was ongoing contact following the emergency department visit, where the social work arm of the intervention was limited to a brief intervention in the emergency department without subsequent contact. Next slide, please. Both arms of the interventionists were generally expected to respond to the ED within 30 minutes. And again, this social work intervention occurred in the ED, and maybe they made referrals to treatments, things like that, but it all happened in the context of the ED visit, where a key distinction with the peer arm is that there was ongoing contact after discharge. Their continued contact protocol in this, we worked with peers through the Anchor Recovery Community Center and specifically the Anchor ED program, was that they were contacted daily for the first 10 days and then weekly for up to 3 months. During that time, at any point of that time, participants could subscribe to ongoing peer support services. And so they could stay in contact with Anchor beyond the 3-month period if they so chose. And you can see the top right is talking about some of the similarities between the two, talking about naloxone and provision of naloxone, and all participants in the study were prescribed naloxone, take-home naloxone in the ED, referred to treatment, and also offered MOUD if appropriate. Next slide, please. These are the 2 key administrative data sources that we use to assess outcomes. The behavioral health online database, and you can see bulleted on the left the various type of programs that we could measure, and then the prescription drug monitoring program, and that was specifically to assess buprenorphine. Next slide, please. And at this point, I will turn it over to Brandon Marshall to walk us through an overview of the participants, followed by study findings, and then we'll open it up for some Q&A. Thank you.
Fantastic. Thanks so much, Francesca. I'm thrilled to be able to present the results from our first paper. But before I get there, I wanted just to talk a little bit about who was actually participating in the Navigator trial. So just to give you an idea of the characteristics of participants who were enrolled, I would say they're relatively representative of people at high risk for opioid overdose in the state of Rhode Island, median age of 37 years. The majority were of male current gender identity, and the majority were of white race, with about 17%, 1 in 5 Hispanic or Latino ethnicity. We did see very many underlying social determinants of health that we know put people at risk for overdose. Although the vast majority had health insurance, we saw a high prevalence of recent unstable housing and also homelessness. Relatively few were employed either full or part-time, and about a quarter of people reported 0 monthly income. So as Francesca mentioned, we had eligibility criteria that included people who were presenting at the ED visit when they were enrolled for an opioid overdose. And that turned out to be about 45% of our participants fitting into that box. But we also had other eligibility criteria. ED patients could have also been enrolled if they had reported opioid overdose in the last 12 months, and that represented about 23% of the sample. And then the rest were presenting for sequelae of opioid overdose, opioid use disorder, as Francesca mentioned, abscesses or opioid withdrawal, for example. At the baseline survey, we measured several different domains, including recent substance use. And you can see those proportions of some of the most common substances endorsed in the past 6 months. I won't list them all, but suffice to say, we saw a high level of extra-medical or non-medical prescription opioid use, cannabis, cocaine, heroin, and also about 40% of our participants had injected in the last 6 months. So due to some incredible collaboration and work with our state agencies, we were able to look prospectively at treatment outcomes, which I'll get to in a moment. And we were also able to look in the 30 days prior to their current ED visit. And when we did that in administrative data, we found that just about 1 in 4 people had received some kind of treatment for an opioid use disorder in the past 30 days before the ED visit. We also asked at the baseline survey through self-report participants' treatment history, and you can see that a relatively high proportion, but not a majority, had reported ever receiving methadone, buprenorphine, and about a third had ever reported a barrier to accessing some kind of SUD treatment. That was often financial barriers, wait lists, or restrictions and rules on programs that they wish to enroll in. So I'm going to get now to our first results. You're the first people that are seeing these results today, so we're thrilled to share them. They were also just published this morning in JAMA Network Open, so you can go ahead and download the paper. This is open access. Brendan, if you could share the link in the chat, that would be great, and folks can download and read the study after the webinar. I'm going to take you through some of the key findings from this paper now before getting to the Q&A. So I'm going to get right to the key results. We found overall that just over 30% of participants accessed any program for SUD-related treatment within 30 days of their ED visit. This was our primary outcome that was defined a priori when we started the trial. And we actually found no difference between the arms. You'll see in further slides, almost the exact same proportion of participants randomized to receive a peer recovery support specialist intervention or a social work intervention engaged in some form of treatment within 30 days of the index visit. So these are the breakdown of the results now. We were able to enroll just under 650 people who were included in the intention, what's called the intention to treat analysis. I don't have the information here, but I will tell you the study arms were very well balanced. And you can see that 30% of people who received a social work intervention engaged in some form of SUD treatment in 30 days, compared to 32% who received a peer recovery support specialist intervention, and that difference was not statistically significant. So as Francesca mentioned, we relied on 2 administrative data sources. We worked with staff at BHDDH to understand access to any licensed SUD treatment program. Most commonly, that included methadone for opioid use disorder or SUD residential programs. A smaller proportion of participants entered into a detox or intensive outpatient program or some other kind of licensed treatment modality. And then we also worked with wonderful staff at the Rhode Island Department of Health, and through consent linked to our state's PDMP to understand whether anyone received a prescription for buprenorphine for the treatment of opioid use disorder. And that was the most common treatment modality accessed. About 18% of overall participants enrolled received a buprenorphine prescription within 30 days of their ED visit. We wanted to look specifically actually at linkage to buprenorphine, and this did not vary by study arm either. 19% of people who spoke with a social worker were linked and were dispensed buprenorphine within 30 days of their index visit, compared to 17% of people who worked with a peer recovery support specialist, and that difference was also not statistically significant. We also conducted a couple of secondary analyses. We hypothesized that people who had recently received treatment would be more likely to subsequently engage in treatment 30 days after the ED visit. And that's exactly what we found. People that had recently been in treatment, about over half of them subsequently enrolled in a new treatment program, like a new admission, or received buprenorphine within 30 days of the visit, compared to 22% of the 472 participants who had not received any treatment in the 30 days before their index visit. And finally, in a secondary analysis, we also looked at the reason for the ED visit. So you recall that just around half of just around 40% of participants were in the ED for an opioid overdose at that visit. So you can see that in my right column. 28% of those participants were enrolled in some kind of treatment within 30 days, compared to 33% of people who were not in the ED that day for an opioid overdose. And we found these findings were particularly interesting. It shows that there's potentially a lot of ED patients who may benefit from these interventions who aren't necessarily presenting themselves in that moment for an opioid overdose. So we're looking forward to hearing your thoughts on this finding and all of the findings during the Q&A session. So I want to talk just at the end here about what comes next for the Navigator trial. We do have a second primary outcome that we will be assessing later this fall. So in addition to treatment uptake within 30 days, we will also be examining whether participants in the trial experience either a repeat or, that should say, new opioid overdose 18 months following enrollment. That follow-up is ongoing. It will end in 2 months from now, in the middle of October 2022. We'll be working with the Rhode Island Department of Health and Lifespan to collect information on both fatal and non-fatal opioid overdoses from the state's EMS system and also from the Lifespan ED records. And we'll be comparing the number and proportion of participants in each arm that had at least one recorded fatal or non-fatal opioid overdose during this 18-month follow-up period. We're hypothesizing that we might see some difference between the arms because, as Francesca mentioned, the peer recovery support specialists do remain in touch with many folks after they're discharged from the ED, whereas social workers really work with the patient just until discharge. And so even though we saw no difference in terms of 30-day treatment uptake, it's possible differences may emerge over this longer follow-up period when we look at opioid overdoses. And we have a lot of other analyses that are ongoing that we're happy to chat more about during the question and answer period. Some of these Brendan Jacka is leading and other PhD students here at Brown. We're interested in diving in a little bit more deeply and understanding if there were any demographic differences between people who were particularly likely to access treatment after they connected with a peer or a social worker. And were there any differences in the sociodemographics between those two groups? We're also looking at patterns of polysubstance use in the sample. We saw earlier a lot and a relatively high level of many substances people report using in the 6 months prior to the ED visit. And so we'll be looking to see whether that is a predictor of accessing treatment, hypothesizing that it is. We've got a couple of other analyses planned as well. As I mentioned, we'll be looking at non-fatal and fatalities, overdose fatalities over the 18-month follow-up period. And then we also have an opportunity to look not only at initiation of SUD treatment, but also longer-term retention and discharges through access to this rich administrative data, working collaboratively with our state agency partners. So I want to wrap up now and open it up to questions that we're happy to answer. But before I do so, I wanted to acknowledge the so many folks that have been critical to this study's success. First, I want to highlight the study participants and their willingness to share their experiences with us and consent to have these data accessed. And also our funders, as Francesca Arnold Ventures was a key partner. We also received funding from the Cigna Foundation. And finally, our wonderful state of Rhode Island collaborators, folks at BHDDH, Linda Mahoney, Jamie Goulet, Mackenzie Daly, Sam Borden, and then also wonderful staff from RIDO, Ben Hallowell, and many others, leadership at both agencies that were willing to partner with us and then to actually carry out a relatively complex set of data sharing agreements and linkage procedures. But it was really such a pleasure to work with these staff throughout the study. And finally, our other colleagues at Brown and Lifespan who actually ran the study on a day-to-day basis. Thank you all for your hard work throughout a particularly challenging time with the COVID-19 pandemic. So with that, I wanted to open it up to questions. Brendan's going to moderate the Q&A. I see some are coming in. And just plug again the paper that just came out this morning in JAMA Network Open that does summarize the key results that we talked about today and has a lot more detail on the study procedures as well. So I might actually stop my share and turn it over to you, Brendan.
Fantastic. Thank you so much, Dr. Baudouin, Dr. Marshall. Appreciate your time presenting the results from this study, and appreciate folks attending the presentation today. I just wanted to respond, first of all, to some questions in the comments, and then I might open it larger for the audience. The first question was from Alice Welch, asking about whether participants were incentivized to participate was the first question. And then the second question was the requirement for obtaining individual consent to match to administrative data. I might pass that to Dr. Baudouin, who was
Sure.
in the ED.
So we did incentivize people to participate in the emergency department. And this actually was an area that was hotly debated at the outset of the study, because we did this in conjunction with our state partners and other stakeholders, including people currently in recovery. And so I believe we compensated everybody $40, and our research staff that did a lot of that recruitment around and can correct me, but we felt like that the study procedures themselves were taking time, and we wanted to appropriately compensate people for their time and not compensate them because of potential bias that, and the kind of the overarching concern was somebody going to take $40 and go out and immediately, buy drugs and overdose, and now we're causing harm. And when we talked to people, we actually found that most of the time that they were using that money actually for things like toiletries and food, and in the end, and there was some, I believe, literature that showed that there was not, increased risk with that amount of money. And so that was basically the amount that we would compensate people for similar study procedures recruited in the ED at that time. And we made sure that when we consented people, that we really, that the mention of the incentive came much later in the procedure, so that wasn't driving the motivation for participation. And then, to the second question about consent, yes, we explicitly and separately got consent. It was part of the same consent process, but to link toward those administrative data because of the separate federal protections and requirements, and our partners at the state agencies reviewed that consent language and to make sure that was in compliance. And so people could participate in the study. They had to sign consent to the intervention, and then separately consign consent to link records. Great question.
Thank you so much for clarifying that, because it is an impressive amount of historical data that you were able to collect in that type of intervention, which was kind of what precipitated my question.
I would say another advantage of the emergency department is that because it has, emergency department has the word emergency in it, it sounds like everything is happening quickly and fast, but the average lengths of stay are quite long. And so that, I think, is also a key advantage of doing public health interventions in the emergency department, is that people are there for hours and they're bored and they're looking for other things to pass the time. And so it is a good time to do all sorts of things, not just, for opioid use disorders.
Great, thank you.
Fantastic. Thank you so much, Alice, for the question. And I just wanted to follow up with that. Excuse me. So Carla Wagner has asked a question relevant to the reason for overdose and whether we'd controlled for prior number of overdose events. The thought being that the perceived salience of an overdose at the time of enrollment may impact people's decision or access to care. Dr. Baudouin, I don't know if you wanted to chat about that as well.
Yeah, and then I'll let Brandon weigh in, and you, Brendan, as well. We did, so a key area of interest, I would say, in general, is looking at treatment of response and heterogeneity of treatment effect. who is responding to an intervention in general, like what are the factors that drive that, and that is something that we're looking at with our exploratory work. And then within the treatment arms, other specific subpopulations which might respond better to one intervention or than other. In our preliminary analyses, we did not really see any difference in treatment effect, looking at kind of overdose versus non-overdose visits, at least not differential between the treatment arms. And so to me, that highlights that the overdose visit is a good time to intervene and talk to people, as well as other reasons why people come to the emergency department, but also have an opioid use disorder. There's been a big focus with ED-based interventions to utilize the overdose visit. But I think that there are other opportunities to engage people besides that visit. And that is partly what I think we're hoping to demonstrate with some of this work. And then the secondary thing about kind of other thing, kind of pre-visit factors, number of overdoses, prior experience with treatment are all, I think, important things to look at. Brandon, you want to?
Yeah, that's a great question, Carla. And just to kind of continue Francesca's point, I think when in the paper itself, we do report an analysis looking at interaction between ARM and prior SUD treatment engagement, and we did not see a difference between ARM. And I don't think in this paper we reported the same thing with prior overdoses, but we did look at that and did not see a difference by ARM, as Francesca mentioned. And then in a follow-up paper, we will dive in a little bit more detail to see if we can identify any other, demographic or substance use related differences in terms of who was accessing treatment after speaking with either a social worker or a peer. But to date, we haven't picked up really very many differences at all. So we'll continue doing that work, but nothing jumping out at us yet.
We did see that across the study participants, that those who had been recently engaged in treatment, so people with a history of treatment, were more likely to, re-engage after the ED visit. So the proportion of people engaging in that 30-day period was higher for those who had had recent treatment engagement. Not to say that people who had never had treatment experience didn't engage, but there were some differences there. And I think that then we're looking at kind of two different things, kind of re-engaging people, recapturing people, and kind of new initiation of treatment. And that's something we're exploring in some subsequent analyses, is new treatment initiation versus kind of re-engagement.
Another analysis that our PhD student Fiona is working on, I just wanted to give you a shout out, Fiona. And feel free to jump in as well if you'd like, as we're looking at also longer term endpoints, specifically 90-day treatment engagement. 30 days was what we defined in the protocol, and so that's what's reported. But in analysis that Fiona is leading, we're looking at 90 days, and we're still not seeing very many differences at all between the two arms. And the rate of treatment engagement doesn't accumulate too much more actually beyond what we saw in the 30-day endpoint. Did I capture that right, Fiona? If I said anything incorrectly, please do so. Please correct me. Yes, okay, I did. Thank you.
One thing I would like to point out about the re-engagement that Brendan mentioned is that with the BHGDH, the behavioral health data set, if folks kind of attended to the same program in the same location, they weren't considered re-engagement because that was a continuation of care. But if individuals access perhaps a new program in their service or in a different location, that was considered a kind of a re-engagement, which our hypothesis being that may be a better fit for them. That if they have connected with a social worker or peer that found a service that is better off for them. So just to be aware that it's some folks may continue in their current care, which was not captured in these outcomes. Fantastic. Thank you so much for the questions. We did have another question from Carla Wagner, whether we had qualitative data from the study, hearing about participants and peers' experiences working in Nevada. I'm not sure if Brandon or Francesca would like to talk about our experience with the qualitative research.
So we did do a qualitative sub-study that is an extension that was funded by our COBRI on opioids and overdose, which is a manuscript that is in preparation, about to be submitted. And there is something to be, said there, and again, gets at this: are there specific people that respond better to different interventions or interventionists? And in general, are in our qualitative work, and again, this is preliminary, not impressed yet. Patients reported to us very positive perceptions of peers and interactions with peers, but also had positive things to say about social work staff, actually in contrast to emergency department clinicians and nurses. So they felt like having someone that was dedicated talking to them about their substance use was really important. And taking the time. And I think for me, that was kind of a key take home message of all of this. We report this in the paper, but our rates of treatment engagement within 30 days of the ED visit are higher than historical averages when we look at quality data from the hospitals and coming out of the Rhode Island Department of Health. And so that tells me that it may, and this is, again, bearing out kind of long, looking at some of these longer term outcomes and the overdose outcomes, that perhaps having someone that can dedicate time and do a behavioral intervention in the emergency department could be more important than who that person is. And for many hospital systems and healthcare systems, they do not have existing infrastructure and staff available to do that. And so there may be a real role for programs like this. And so at first glance, this kind of comes off as a negative study, but then when you take a step back and kind of look at the bigger lens of what's historically been happening, there were very high rates of treatment engagement across the study arms, just not kind of, there's not a difference between the two. And we're trying to bear out, what does that look in the long term? What does that look for other outcomes like opioid overdose that we know can be impacted by other harm reduction practices and interventions? And then again, is this, and then Alice Welch mentions in this follow-up question is looking at the effects of post-ED engagement, and we don't have this. So this is really the first finding of the overarching aims of the study, and we'll need to drill down on these other questions before making widespread, clinical practice and policy changes. So there's some encouragement there, but this is a negative study, but with some very important lessons learned and things that can inform both practice and policy.
I think the one other thing I would add too is that, and Francesca, maybe you can comment on this, is that there were some misconceptions about, negative opinions of MOUD therapies specifically that were held by peer recovery support specialists, opinions held by providers, ED doctors, nurses, or whatever, in terms of peers being unwilling or less likely to recommend MOUDs for patients. And I think what this finding does show is that this does not seem to bear out in the data, as we showed, uptake of methadone, buprenorphine were equally likely between the two groups. So I think that's another important piece that we were hearing as a concern, and that I think this trial pretty confidently rules out.
Yeah, thank you, Brandon.
Fantastic. Thank you so much, Francesca and Brendan, for responding to both Carla and Alice's questions. We had a question from Will Goodell about the kind of demographic characteristics of the peer support or peer recovery specialists and social workers. Do you have any insight on the type of individuals and their kind of concordance with the participants, or whether that may have impacted the outcomes?
Great question, Will. And, at the end of every study, you always have things that you wish you had done differently at the outset. And I think there was a missed opportunity to collect that information about, socio-demographic concordance between the interventionists and the participants. And so unfortunately, we don't have that information. But, what Will, I think, is getting at, and what's important is that do the characteristics of the interventionists matter? And, for instance, a very clear example where it matters is we only enrolled English speaking participants because our pool of interventionists did not, so common languages in those emergency departments that might have been spoken would be Spanish, Portuguese, probably first and second in terms of prevalence. And we did not have enough Spanish and Portuguese speaking interventionists, particularly, in terms of follow-up after the hospital. So in the hospital, we can get an interpreter. We have interpreter services to cover a wide array of languages, but it was that ongoing contact with the peers that we did not have the ability to support other languages. And so that's a very clear example of where, those characteristics of the interventionists are driving who can receive and benefit from the intervention. And it may very well differ across other socio-demographics. So an interesting area of study that we can recommend for future work.
Fantastic. Thank you, Francesca. I did have one question coming off the back of that, which is more broadly, is there the capacity within the behavioral health treatment setting once for people who speak another language other than English? So if we're able to provide, say, Spanish or Portuguese speaking support in the ED, is there a service in the community that they would then be able to provide or connect that patient to? Do you have thoughts on whether there is a broader issue of culturally and linguistically diverse providers that would need to be addressed as well?
Yeah, I'm not, I am not sure. And that actually probably the fact that I'm not sure gives you a good hint that it's an area that we need to do better. In more of, healthcare settings with more robust infrastructure, there are interpreter services. And so depending on the environment where somebody's engaging, if it's within the hospital system, then interpreter services is available, even when a clinician may be, primarily English speaking, but their patient is not. In more community-based organizations, I would speculate that is more of a challenge in an area where we probably need to build out better services, particularly when you're looking at parts of the country that might have larger populations of community members who speak a language other than English as their primary means of communication.
Fantastic. Thank you so much. We had another question from Alice, another fantastic question. Specifically about the harm reduction techniques or kind of offerings in the emergency department other than naloxone, take-home naloxone and MOUD. Is there any, can you give any insight onto what the peers or social workers may have provided during the intervention?
Yeah, I can take on the peer side, the training is focused on applying harm reduction principles. And so peers work with the patients to understand, what they might benefit from in terms of harm reduction or other resources, treatment, housing, and so on and so forth. So the peers, depending on the patient's need, may work to connect the patient post-discharge with our statewide syringe service programs, for example, in addition to, say, the naloxone that would be prescribed or dispensed at the ED visit. So that I don't know how often that happens. Unfortunately, we don't have that data, but I know that is part of the practice. Francesca, do you want to talk about the social work side?
Yeah, the social workers also receive training in harm reduction approaches, although I would say that the larger focus in the emergency department probably does fall to naloxone and MOUD, but they definitely receive training. And with both interventionists, they're guiding what they talk about and the behavioral intervention based on the individual patient and their needs and what that person is expressing to the interventionists. And so the interventions really are tailored. One thing that I will say is that we did not standardize along that line, did not standardize the intervention. And so in many ways, this is a pragmatic trial. There were training of both groups of interventionists about the study and kind of a general training at the outset, but then ongoing training was really left within the arms of the study to what their normal trainings would consist of. And there were many interventionists. And so there's a lot of heterogeneity between the interventionists themselves. And so this is kind of, I think, what you would get in a real world setting rather than a tightly controlled trial with high fidelity. So there's clear advantages and disadvantages to both approaches, but we felt like this was a really pressing question and we wanted to approximate what was happening in the real world setting.
Fantastic. Thank you so much. I had a question for Brandon, just as we're leading into wrapping up, is that you have a lot of expertise with administrative data linkage for research outcomes. Did you have any advice for people that are doing similar research? Anything that they should or need to know as they get into administrative data linkage?
Yeah, that's such a great question, Brendan. Like, we're very fortunate here to have a few things in our favor, wonderful relationships with our state agency partners, a single statewide Department of Health. So we are small in the state. And so essentially we can go to one place to get a pretty good statewide picture, which I know is not the case in other states necessarily. But my advice in general would be to, develop rapport with and get to know those state agency staff. They're experts in the data. I've learned so much from the nuances of what these data mean, how they're collected, what is the actual data generating process when someone is admitted into a licensed SUD treatment program, for example. What are, some of the challenges with the data or the limitations? So that's the knowledge that state agency staff bring to the table. We do all of our work very much in collaboration. We do not, and I do not recommend a system, and this happens, and this has happened in the past, where researchers sort of take the data and then run with it, and then that's it. There's really no collaboration from that point forward. So, that's my recommendation for folks who are willing to engage, who want to engage in this kind of work, is to have those conversations, develop relationships, and work collaboratively with the experts at these places. Understanding also that they're busy people and that this is often, off the side of their desk, they have full-time jobs. So there's also just acknowledging, I think, to what is like realistic. And I want to give you a shout out, Brendan, as well, because you did a lot of the hard work to actually make these linkages happen and manage the secure data transfers and so forth. So I do want to highlight, it takes resources and expertise and folks like Brendan to make that happen. So thank you, Brendan, and everyone for getting us to this point.
Fantastic. Thank you, Brendan. I appreciate that. And I would also say that I'm working off the back of many people at Brown and Department of Health and BHTDH who have done all of this work before. Brown University is very fortunate to have a secure data environment where we can work with HIPAA data sets. So folks in other jurisdictions may have some other challenges, but feel free to reach out to us and we can let you know what has worked for us.
Yeah.
Running up to the end of the session, I just wanted to open the floor. If anyone had any other questions or thoughts that they would like to share, feel free to raise your hand or drop it in the chat. We appreciate you joining us and just wanted to hear your voice if there's anything pressing. And of course, appreciate the engagement that we've had so far. Fantastic. I might just, if people are kind of formulating any thoughts and typing up at the moment, I just check in with Brandon and Francesca about the second primary outcomes. You said that the results, or we said the results of the data will be available in October. Do you have any kind of thoughts on when we might have those results available to the community?
Yeah, great question, Brendan. This is something we've been talking a lot about. We're fortunate that the non-fatal overdose records are, really very timely. And so we can start to look at those, I think, pretty quickly after the 18-month follow-up is complete. The fatalities are a little different. There's longer term delays in investigating and closing those cases. And so one thing we're thinking about right now is whether to focus for the time being on non-fatal overdoses, get that information out to our partners and to the public, and then wait a little bit longer to look at fatalities as an exploratory outcome. So I think if we do that, I'm pretty confident we can move quickly on looking at the non-fatal overdoses from EMS records and also from the lifespan ED records as well.
Fantastic. Thank you so much. With no further questions from the audience, and I've run through all of mine, I think we can end a little bit early. I thank you everyone for attending and for joining and hearing about the results from the Navigator trial. We're very happy to share these that we believe are some of the first results comparing social workers and peers in the emergency department, and hope that these results can be helpful for you in your research or your practice. I'm just going to drop in the chat again the citation and the link to the article. Folks can get it open access, so feel free to share on Twitter, tag us. Our Twitter account is pph_collective if you want to get more information about us. Thank you, Dr. Marshall, Dr. Baudouin, and everyone for attending.
Thanks so much, everyone.
Thank
Bye-bye.
you. Bye.
Take care.
Cool.